Priya.
Yeah. A very good morning. I'm sure I'm audible, and it's a pleasure to see you all and at this August morning. So today I'll be speaking about the ultrasound guided femoral access, especially. So why we get patients of various different habitus in our cath lab. Some of them are chubby, they have high subcutaneous fat, and this may obscure the landmarks and make punctures difficult. Anatomical variations are well known in the femoral artery, and hence ultrasound comes to the rescue. In patients who have low blood pressures, the vessels tend to collapse and access becomes difficult. And in situations such as very tight coarctations, the pulse is not palpable at all. And moreover, it's the standard of care because it increases the success rates, decreases the access time, and decreases the complications. So 80% of the battle is won if we have a right setup. And what does a setup mean is that first thing is positioning of the patient. We all know how the table height matters. Placing a boulder below the sacrum helps to extend the hip and gets the vessels closer to the skin surface. Always place the ultrasound machine in front of the operator and the level of the screen at the level of the eye of the operator. Now, this is very crucial and very important because with this, there is the ease of the procedure is highly enhanced. If the machine is placed anywhere else, you need to rotate your head every time, and then that makes the procedure quite cumbersome. So positioning of the patient, the second is selection of the probes. So we need to select a probe which has a linear footprint and a high frequency so as to delineate the superficial structures better. So we in the cath lab here, we use most of the times the hockey stick probe or the L12-3 probe. Now, selection of the preset is the next point. We select the superficial vascular preset again to get better imaging, and then the orientation of the screen. So you change the screen orientation left, right, so that the pointer comes to the right of the screen. This is how we are used to hold our echo probes as well, where the pointer is to the right of the operator and the screen as well, so that whatever is seen on the right of the screen is on the left side of the body. Now, this is very important when we are moving the probe or we are trying to hit the target. So we know whether we have to angulate the needle medially or laterally and so on. So once this basic setup is done, things become quite easier. Then we start the dry run. Now, why do we do the dry run is that we just want to adjust the machine, to adjust the gains of the machine, to adjust the depth so as the structures are quite well visualized. And we also do the color Doppler imaging. So this is a dry run just to have a better image already ready before we get scrubbed in. Now we start preparing the probe. The patient is now scrubbed up and everything has to be sterile. So we get this kind of a kit, which is called the probe cover kit, wherein we have a plastic cover. And this, I'm trying to reach the edge of the plastic cover. It is a blind edge because the jelly goes in there. And I want to do this because I want to invert the plastic probe so as the jelly does not touch my gloved fingers. So in New Zealand, where I used to work, we used to get the complete kit with a sterile jelly packets. And then the operator could do all of it by themselves. But here, what we get is we don't get the sterile jelly packets. So the assistant has to pour the jelly in. So that is how I invert the plastic cover. And I make sure that when the assistant is pouring in the jelly, and use of liberal jelly is very important, but when the assistant is pouring in the jelly, it should not splatter over my gloved finger. So the jelly bottle has to be full, and the assistant has to be really gentle in squeezing the jelly out onto the probe cover. Cover the probe as well as the plastic cover with jelly. And now securing is also very important because see, we need to get the edges of the probe very right, because in this way we have to actually find the center of the probe to puncture. And if there are any loose plastic edges, then the needle might actually pierce the plastic before entering the skin, and again the sterility will be challenged. There should not be any air bubbles in the jelly, because again the imaging becomes very obscure if there are any air bubbles, and a nice layer, generous layer of jelly should be over the probe. This step is the most crucial, I think, in the whole process, because this is where the imaging clarity is going to come. So covering the probe is very, very important. Now, before we start imaging, I would like to tell you more about the various axes. I use the transverse axis in my femoral cannulations. Now, this is because it's easy, it's recommended for beginners. In this way, we can identify the surrounding structures quite better. So we do not puncture the artery when we actually intend to puncture the vein. Here we cut the vessel like a loaf of the bread. The only drawback in this situation is that we can only see the needle tip. So now the trick here is identifying the needle tip is the most crucial, and the trick is first to slide the probe up and down so as to lose the needle and then get it back. So then we know that we have started from the tip of the needle. Again, we use the bevel edge up so that the bevel edge faces the ultrasound probe. In this way, the ultrasound rays get reflected and you can see a bright star-like structure, and it is very hyperdense as compared to the shaft, which is hypodense. Some people also use longitudinal imaging, wherein they cut the vessel so that it looks like a tube. Now, this is a relatively difficult. It has a relatively longer learning curve, because the axis of the ultrasound beam, the needle, and the vessel all have to be exactly in the same plane. So if your dexterity is not good and the hand is not steady, then you might actually end up piercing the wrong structure. This is very helpful for shallow structures, and here the entire needle is seen. But again, the learning curve is difficult, so I would henceforth I'm going to discuss about the transverse or the short axis view. This is how I place the probe over the inguinal ligament, and the transducer is facing the right. Now, hand movements. So what kind of movements do we make? We move the hand from the head end to the leg end to select the puncture site just before the femoral artery bifurcates. Now, rotational movements can be done to actually separate the artery from the vein. Angulatory movements for better imaging. And then the pressure has to be really adequate so as to not obliterate the vein, which is a very collapsible structure, but good enough to get good imaging. So here, if you see, anchoring the hand over the patient helps, like how we do in the transthoracic echo as well. Steadiness of the probe is quite crucial, because once we start puncturing, this hand has to move very steadily. So the non-dominant hand holds the probe and the dominant hand punctures. Now, when I give the local anesthesia as well, I try to indent the skin so that when I am seeing on the screen, I know exactly which point to puncture. So now we start imaging the vessels. These are the steps for the venous visualization. You get the vessel which you want to puncture at the center of the probe. Then you do a little bit of compression to just identify that the vessel is a vein, because there are many ghost-like structures. If you even see in the same image, you can see a structure which is above and to the left of the screen, which also may be a vessel. So color Doppler imaging here is very important. All those structures won't take color and only the vessels will take color. And again, pulse Doppler interrogation, if you are still in doubt, you can see the phasic flows in the vein. Similarly, for identifying the artery, you get the artery to the center of the probe. It is a pulsatile structure. And then you start doing the color and pulse Doppler interrogation. Now, once we have identified the vessels, we begin with the puncture. Now, the site of the puncture should be around 1 inch below the inguinal ligament. Now, why is this so? This is because the ultrasound beam can reach, and we can see the whole needle as it crosses from the skin surface to the vessel. And again, the bevel side should be up. So this is the venous puncture procedure. I get the vessel at the center of the probe. I start puncturing 1 inch below the level of the probe. and I move my hand and the tip of my needle, angulate it so that the needle tip is seen. If you can see it on the screen of the ultrasound machine, there we can see a very bright, shiny structure which is inside the vein. And this, we don't want to counterpuncture it. We just want to enter the lumen, and then we start aspiration. So again, to emphasize that identifying the needle tip, you can actually lose the needle and then get it back so that you know that that is the tip of the needle and not the shaft of the needle. So the rest of the procedure is the same. You once you have entered the vessel, you aspirate and then you cannulate. So you see a good backflow from the vein. In this procedure, I do not use any fluoroscopy because I have done the punctures in vision. I have seen that I have entered the right vessel, so I do not need any fluoroscopy for my punctures. Again, this is the arterial puncture. I get the artery in the center of my probe, and I select a point at exactly center of the probe because my artery is in the center of the screen, and I start puncturing 1 inch below the level of the probe. So again, in this picture, you can see that the needle tip is exactly inside the artery, the lumen of the artery. And the procedure is so simple. You get a very good backflow and then you cannulate the artery. So the take-home message today I would like to tell you all is you should start using ultrasound in all cannulations, not only when the situation arises, because in case of dire situations, you actually need that practice and that confidence, which is you achieve after a lot of practicing in big patients and normal patients. Use transverse imaging. Imaging the needle tip is very crucial. Insert the needle with bevel facing up and down hand movements, and changing angulation of the needle tip are the tricks to identify the needle tip. And what more, it is recommended by Agency of Healthcare Research and Quality as top 11 proven scientific practices. So should we do it in all? The answer is definitely yes. Thank you and all the very best.